Welcome to the Virtual Infectious Disease Congress, sponsored by Johns Hopkins University School of Medicine on ID Care Live. My name is Dr. Ruth Karen, and you are tuned in to a live CME session called Vaccine Game Changers. I'm professor in the Department of International Health, Johns Hopkins Bloomberg School of Public Health, director of the Center for Immunization Research, and founding director of the Johns Hopkins Vaccine Initiative. Before we get started, I would like to remind you that I will be taking questions in real time throughout each presentation. You can send me your questions anytime during the program through the box in the lower left-hand side of your screen. So the topic of my talk today is updates from the Advisory Committee on Immunization Practices, what's new and what's on the horizon. And we're going to be talking about two topics today. One is prevention of pertussis in young infants through maternal immunization, and the other is about influenza, new viruses and new vaccines. So first we'll talk about pertussis. And I have a little quiz for you. You're going to be able to vote. Here's the case history. A 33-year-old para-2 gravida-1 woman comes for a routine prenatal visit at 32 weeks gestation. Her previous pregnancy 3 years ago resulted in the birth of a healthy term infant who is now 2 years old. During that previous pregnancy, the mother received Tdap vaccine. What advice do you provide regarding immunization against pertussis for this pregnancy? A, do you say no immunization is needed since Tdap was administered in an earlier pregnancy and immunity is long-lasting? Or B, Tdap should be re-administered during this pregnancy? Or C, Tdap should be re-administered postpartum, preferably within 2 weeks of delivery? I'll give you a minute to answer. Okay, and so what I see most people are saying, about 70% of you are saying no immunization is needed since Tdap was administered in an earlier pregnancy. About 20% of you are saying Tdap should be re-administered in this pregnancy, and about 10% of you are saying it should be re-administered postpartum. So the correct answer currently, with our current thinking, is that Tdap should be re-administered during this pregnancy. For those of you who answered A, and that was most of you, that's not surprising because up until about 3 weeks ago, the recommendation was just a single dose of Tdap in one pregnancy and that was sufficient. But we're going to talk about why we don't believe that is sufficient and why the ACIP recommendations have changed. So first, let's start with why immunize pregnant women against pertussis at all. Why that group? And this slide just shows you the reported pertussis incidence by age group from 1990 to 2011. As you can see, and as I'm sure you all are aware, we are experiencing an upsurge in pertussis. There's particular increase in children under a year of age, and also there's an increase, as you can see, in that a smaller increase in that 7 to 10-year-old age group. For those of you who are interested, as an aside, there's an article in JAMA this week about reasons. This is a large study in California that looks particularly at that 7 to 10-year-old age group and talks about waning immunity after the 5th dose of DTaP vaccine. But for today, what we're going to do is focus on those very young infants, the less than 1-year-old, and you can see that those children are at particular risk of pertussis. And in addition, as you can see, pertussis deaths occur in young infants and in very young infants, infants under 3 months of age. As this slide makes clear, and the other slide suggests, part of the problem and part of the reason that we see severe disease in the very young infant is because pertussis occurs in those infants prior to infant immunization, we give the primary DTaP series within the first year of life, but the first dose is not given until 2 months of age. And there's a substantial burden of pertussis in very young infants under 2 months of age. Because providers are sometimes confused about the types of vaccines available for children and for adults, I thought I'd just take a minute and talk about the differences between these vaccines. So the vaccine that we use for children under 7 years of age is called DTaP. And as you can see, I've shown in red the D and the P are capitalized or uppercase for DTaP. And that's because the concentration of diphtheria and pertussis antigen is higher in the DTaP preparation. And there are a number of vaccines, both individual vaccines made by manufacturers, and those are shown on the right-handmost column, Dapticel, Infanrix, and Tripedia, as well as various combination products with hepatitis B or IPV. Tdap vaccine, which is mostly what we're going to focus on today, was licensed in the US in 2005. It has a lowercase d and a lowercase p, and that's because it has less diphtheria and pertussis antigen. It is licensed for use in adolescents and in adults. And in the US, there are 2 preparations of Tdap vaccine, called Adacel and Boostrix. So how do we use pertussis vaccines in the US? As I'm sure you all know, we give 5 doses to infants and children of DTaP at 2, 4, 6, 15 to 18 months of age, and 4 to 6 years of age. In adolescents and adults, we give 1 dose of Tdap, preferably at 11 to 12 years of age. We also immunize healthcare personnel and pregnant women, as we'll talk about. We also do recommend cocooning, and what that means is that when a young child is born into a family, we recommend that family members and those caring for the child, if they are not up to date on their pertussis immunization, do get a dose of Tdap to help protect the very young infant. So what was the old recommendation, the old being 2011, for Tdap in terms of pregnancy? ACIP recommended that women's healthcare personnel implement a Tdap vaccination program for pregnant women who previously had not received Tdap. And this is essentially that choice A in that early polling question that I gave you. That was the old recommendation, a single dose in women who had not previously, pregnant women who had not previously received Tdap. But why are we thinking to do something different? Why isn't 1 Tdap immunization in pregnancy enough? Well, the problem really has to do with the nature of the acellular pertussis vaccine that we use now and the waning of antibodies. And this slide shows the persistence of pertussis antibodies 3 years after Tdap vaccination of adults. And you can see that the immunity wanes quite rapidly. It drops fairly precipitously in the first year after immunization and then levels off. But there's a really sharp decrease in antibody levels. And this, so that's the science. Does it, the question might arise, well, does that loss of antibody mean something practically and clinically? This is just a single case history from Texas this year of fatal pertussis in an infant born to a mother who received Tdap 2 years earlier. So this was a baby who became ill at 8 days of life and was hospitalized at 32 days of life. He was positive for pertussis by PCR. He was intubated, had mechanical ventilation, and received ECMO, and died at 40 days of age. The mother developed a coughing illness 1 week prior to delivery, and she had, in fact, received Tdap postpartum 2 years prior to this, when she had her last child, 2 years prior to this pregnancy. 2 of 3 of this child's siblings were ill, and may have been ill with pertussis, though we don't have culture or PCR confirmation of that. And as is obvious from the statement above, this mother had received Tdap vaccine postpartum from the previous pregnancy, but this did not protect the infant. So what now are the new recommendations? The new recommendations are that ACIP recommends that providers of prenatal care implement a Tdap immunization program for all pregnant women. Healthcare personnel should administer a dose of Tdap during each pregnancy, irrespective of the patient's prior history of receiving Tdap. If not administered during pregnancy, Tdap should be administered immediately postpartum, though there is a strong preference for immunization during pregnancy. The reason for that is that provides for maternal transfer of antibody to the infant. Administering Tdap postpartum prevents pertussis in the mother, but it doesn't provide passive immunity to the infant. So in trying to implement this new recommendation, what do we need to think about? Well, there are a couple of things. One is we really need to focus on improving Tdap coverage. And the other is, now that we're talking about giving multiple doses of Tdap to pregnant women, it's especially important to think about monitoring for adverse events. So let's talk first about pertussis vaccination coverage. So we do very well in this country with immunization of children. Over 95% of children have received the primary series of DTaP, and 95% complete the 5-dose series with school entry. We don't do too badly with Tdap in adolescents, and again, that's because we have some school requirements in many states. So about 3/4 of adolescents are immunized. But our record of immunizing adults is pretty dismal, and I think it has to do with our lack of clear mechanisms for encouraging adult immunization. So only 8% of all adults received Tdap, and only 2.6% of women received Tdap vaccine during pregnancy. So how can we improve this coverage? Well, one of the things that we know is that provider recommendations are the best predictors of vaccination. So it's really important that providers are educated about the importance of providing Tdap during pregnancy. The other thing is that the new recommendations may help because there are also studies that have shown that providers have hesitated to vaccinate if Tdap vaccination history is undocumented. The problem arises if a pregnant woman is coming for prenatal care, this is not her first pregnancy, and her Tdap vaccination history was unknown. Many providers in the past would have hesitated to give Tdap because they didn't know the woman's vaccination history. Now that the recommendation is to provide Tdap with each pregnancy, that barrier should be removed. There have been several initiatives aimed at improving vaccination of pregnant women. Communications from the Center for Disease Control and from the American College of Obstetrics and Gynecology, a relatively new service, a text messaging service called Text for Baby, which pregnant women can sign up for and which provides a lot of information about prenatal care throughout the pregnancy. And monitoring efforts that are conducted by the CDC. One example of these is something called PRAMS, which is the Pregnancy Risk Assessment System. So what about safety monitoring for pregnant women vaccinated with Tdap? And the concerns that have arisen as people have thought about safety are particularly the concerns about giving multiple tetanus immunizations and worries about whether there might be a small risk of an Arthus reaction in association with multiple doses of tetanus vaccine. So the mechanisms that are in place for monitoring this phenomenon or any safety issues associated with Tdap are the monitoring systems that are in place for all vaccines used in this country. There are two of those. One is the Vaccine Adverse Event Reporting System, which I know all providers are familiar with, and that's a passive reporting, passive surveillance system administered by the CDC. There will be particular attention and enhanced monitoring for adverse events in pregnant women following Tdap through the VAERS system. In addition, there's something called the Vaccine Safety Data Link, which is an active surveillance system that works through several large care organizations throughout the United States to gather data on adverse events following vaccination. And the VSD group will be implementing studies assessing acute adverse events, adverse pregnancy outcomes affecting the mother and birth outcomes following receipt of Tdap and other vaccines during pregnancy. So one question that arose during some of the ACIP discussions of Tdap was, how many doses are we talking about? If we say that a pregnant woman should receive Tdap during each pregnancy, how many doses does that represent? And this slide just shows the number of pregnancies a woman is likely to have. It's listed as the number of children ever born, so it's not a perfect counter of pregnancies, since certainly there are pregnancies that are terminated early, and there are also multiple births. But as you can see from this slide, if you look at the blue shaded area, most women have 3 pregnancies or less. It's really very few women who have 4 or more pregnancies. So we're not likely to be talking about 10 doses of Tdap or 5 doses or even 4 doses. We're more likely to be talking about 1, 2, or 3 doses, and unfortunately, I think it will be great when we have the problem of considering 3 doses of Tdap. We have so far to go right now with increasing coverage in pregnant women when the current coverage rate is hovering around 2 or 3%. That we'll be in a good place when we have to worry about multiple doses. But even those multiple doses, we're really for the most part talking about 2 or 3 doses of Tdap. So the summary here is that for maternal Tdap is that a single Tdap immunization does not provide durable protection through multiple pregnancies. The strategy of Tdap immunization with every pregnancy will provide better neonatal protection against pertussis. Efforts to improve immunization coverage with each pregnancy are needed, and passive and active safety surveillance is ongoing. I'm going to pause for a second and just take some questions. The first one that I have is a question that says, is it better to wait to vaccinate during the pregnancy, or should women be vaccinated during the preconception period? That's a great question. And the answer is we should wait to vaccinate until the woman is pregnant. It would be ideal if we had a vaccine that we could administer during the preconception period. But if you focus on that slide that I talked about that showed waning of immunity, and I think I may just try to go back to that slide to show you again. We'll get there. Yes. Okay, so this slide that shows waning of immunity, you can see that you lose a lot of antibody in that first year following vaccination. So the problem with preconception immunization is that by the time the woman gets pregnant and delivers, she won't have much antibody. It's unfortunately a function of the acellular pertussis vaccine. Okay. Okay. Another question is, do you think healthcare providers should be provided with Tdap at the expense of the employer, since most adults have had only TD boosters? We offer it to new hires, but employees who have been with us for a long time haven't had it, and many aren't even aware. I think that's a good question. I personally believe that that we should be providing Tdap to everybody, and that it would be worthwhile to go back and administer Tdap to individuals who've only had TD. And I completely understand the question, because new hires get Tdap, but people who've been around for a while only have received the old TD. So I actually would encourage wide-scale immunization of adults with Tdap. There's a question here about, are there any drawbacks to receiving multiple Tdap vaccines in adults? I think I may have touched on that a bit. We talked about the fact that people have concerns about whether you might develop Arthus reactions with multiple tetanus vaccinations given very close together. Those reactions are very rare. We wish we had better data on this, in resource poor settings. Tdap is not given, but maternal tetanus vaccine is administered very frequently. And often women in those countries, some of them have gotten 5 doses, some of them have gotten 10 doses, although safety reporting is not ideal in many of those settings. We don't hear a lot about Arthus reactions, serum sickness kind of reactions. So what I would say about this is it certainly needs to be monitored, and we talked about the mechanisms for monitoring it, but I believe that the risk is small. There's a question about, in the fatal infant case presented wherein failure of maternal Tdap is suggested, is the previous immunization of the mother, in other words, did she get childhood adolescent immunization, and siblings, household contacts known? I know that the siblings and household contacts of this infant had been immunized against pertussis. I am not certain whether the mother's pertussis immunization history is known. So there's a question, after the initial Tdap, should the next booster be Tdap or TD? So when we're talking about pregnant women, so right now the recommendation for adults in general is a single dose of Tdap, with the exception of pregnant women who receive a dose with are now recommended to receive a dose with each pregnancy. And those women should get Tdap with every pregnancy. They shouldn't get TD after their initial dose of Tdap. Okay. There's a question, could I clarify what is the rationale for giving Tdap after each pregnancy? Non-pregnant adults only get 1 booster shot. Thanks. So just to try to make clear a couple of things. One is Tdap not after each pregnancy, Tdap during each pregnancy. The rationale is really this issue of waning immunity and risk to the very young infant. We know that young infants are at greatest risk of acquiring pertussis and of dying from pertussis. Giving an immunization in pregnancy protects in 2 ways. it it prevents pertussis in the mother, so there's not transmission of pertussis from the mother to the infant. It also protects the infant by passive antibody transfer. So the mother's antibodies are boosted when she's immunized. Those antibodies are passed on to the infant. So there are two mechanisms of protection of the young infant. There's another question. Is it necessary to test antibodies in pregnant women after vaccine administration? No, we don't recommend testing for antibodies. There have been enough studies at this point of immune responses in pregnant women to know that the patterns of response are similar to what we see on this graph. We don't, in general, we don't see vaccination failures, as has been reported with other vaccines, for example, hepatitis B. So there's no need to test after you immunize. This is a great question. The question is, should we keep working on better vaccines, i.e. one resulting in longer immunization? So I think the question here is, again, I keep coming back to the graph that's displayed before you. This isn't, we would really like a vaccine that gave longer lasting protection, and I think that that would solve a lot of problems. I think it would decrease pertussis in the community, because clearly we're seeing pertussis that's in part the result of waning immunity. And we could imagine that we would get to a point, if we had a better vaccine, where we didn't have to keep immunizing in every pregnancy. I think there is tremendous interest in that. I think that it's going to take, you know, the question is whether companies are going to want to be working on producing those kinds of vaccines. If you're really interested in this question, there is a very nice review article by Dr. James Cherry that was in the New England Journal of Medicine in August of this year. And I would refer you to that. And he talks specifically about the need to develop better pertussis vaccines. Oops. Okay. I think we're going to finish up with one last question that's asked, how late during pregnancy can you still give the Tdap vaccine? And the answer is that the optimal time to give it is in the third trimester, probably after 32 weeks. Obviously, you would like to give it a couple of weeks before delivery if you can, to allow for transfer of antibody from the infant, from the mother to the infant rather. But you shouldn't, you can give it at any time prior to delivery in the third trimester. And if the worst comes to the worst, it's essentially like giving the mother a postpartum dose. It will still protect the mother, which may indirectly protect the infant. Even if you immunize only days before delivery, there will still be some transplacental transfer of antibodies. So there isn't a late contraindication to giving the vaccine. I thank you all for your questions about pertussis. I think we're going to move on now, and we're going to talk about influenza. Okay, so there are two topics that I'd really like to talk about with influenza. One is H3N2 variant virus, which you heard a lot about this summer, and the other is something that we don't have in hand yet, but we're going to have very soon, and that is quadrivalent influenza vaccines. So first, human infections with influenza H3N2 virus. So what is H3N2 variant virus? You heard a lot about it, as I said, this summer. The V, as I mentioned, stands for variant. This is a reassortant that contains swine H3N2 influenza and the matrix protein gene from H1N1 2009. So you can see in this little cartoon that on the left panel of the cartoon is the swine origin H3N2. On the right panel is the influenza A H1N1 2009. And in the middle panel is this H3N2 variant virus that has all the genes from swine H3N2 except for the matrix protein from H1N1. One important thing to note about this is that even though our influenza vaccines contain influenza A H3N2, those are human origin H3N2s, and our current influenza vaccines therefore do not protect against this swine H3N2 variant virus. And as you can see, influenza is a segmented virus, and it reassorts, and human and swine influenza reassortant viruses have certainly been described for many years, but we've had a real upsurge in this H3N2 variant virus. It was first recognized in 2011, and there was a big uptick, as you all know, in 2012. This slide shows where those cases occurred. And as you know, most of those cases occurred in the Midwest, in Indiana, in Illinois, and Ohio. There also were some cases in the Mid-Atlantic. Most of these cases also occurred during the summer, July, August, and into early September. This slide just shows the total number of confirmed cases as of mid-October this year. And this slide shows the epi curve of these cases. And one of the things that was really very interesting about these cases is that most of these occurred in school-age children. The mean age of the cases was 8 years, although the range was from early infancy to elderly people. The incubation period was 2 to 3 days. The secondary attack rate was very low. Symptoms were very much influenza-like, so sore throat, fever, malaise, myalgias. The duration of illness was 3 to 4 days. The period of infectiousness we don't really know for this virus, how long somebody is contagious. What do we know about the exposures? Most of the cases, most of these, in fact, young school-age children had either direct swine contact, indirect swine contact, or attended a fair. More than 50% had multiple days of exposure. And many of the cases were young children who were exhibitors of swine through farm extension programs, or families and friends of these children. Just to put this into context, it does sound like a lot of cases, but about 200,000 children and adolescents exhibit swine each year at state and county fairs in the U.S. So, as I'm sure all of you heard this summer, there was a lot of concern. There were many cases noted in July, and August is usually the big state fair month, and there was a lot of concern about should there be pigs at state fairs, what should happen when people go to pig barns. So what was the risk to fairgoers? It was unknown but assumed to be low. There are many people who go to fairs, over 80 million people a year, and about a third of those visit the swine barn. So many people were potentially exposed briefly and indirectly, and some of these would have been exposures would have been to infected pigs. But few cases have reported brief and transient exposure. As I mentioned, it was really primarily these young children who had daily close contact with pigs that were infected. And I should mention, it's not on the slide, but I should just mention that the illness that was seen with H3N2 variant virus was very similar to the kind of illness that we see with human influenza seasonal viruses. It was typical, and it wasn't in any way more severe than what we typically see with influenza. So, conclusions about H3N2 variant. Fairs are places that pigs come together, and if one or more pigs are infected, there's transmission among pigs, and sometimes there's transmission to people. The people with direct and prolonged exposure have been those at risk of H3N2 variant infection to date. The risk of H3N2 variant infection was low in exhibitors and very low in casual visitors. There were no H3N2 variant cases arising in the general population without exposure to pigs or to sick people. We don't know of any significant person-to-person transmission, and there was no community transmission. In most people, the illness was short and self-limited. Very few were hospitalized. There was one death. So that's what I have to tell you about H3N2 variants. We can discuss them during the question and answer session if you'd like. I'm going to move on now and talk about quadrivalent vaccines for influenza, something new that's coming soon. So why are we thinking about quadrivalent flu vaccines? The current vaccines that we use, whether they're inactivated vaccines or live attenuated vaccines, contain 3 influenza strains: A H1N1, A H3N2, and a B strain. And as you know, these viruses, these strains in the vaccines are updated each year. The one B strain virus that's included in the vaccine comes from either the B Yamagata or the B Victoria lineage. B Yamagata and B Victoria are very antigenically distinct, and there's not much cross-protection induced by these strains, particularly in young children who haven't had repeated exposure to influenza B. And even though we use surveillance to decide what to put in the vaccines, we haven't done very well when it comes to influenza B. So we have correctly predicted whether a B Victoria or B Yamagata strain virus will circulate about 50% of the time. For all of our surveillance efforts, we would have done equally well if we had just flipped a coin. So what about the burden of influenza B disease? Why does it matter if we're wrong? And influenza B comprises about 20 to 25% of the circulating seasonal influenza strains. And influenza B associated hospitalization rates are less than those associated with H3N2, but they're greater than those associated with seasonal H1N1 in all age groups. So they sort of have an intermediate level of hospitalization between those two influenza A viruses. In children, myositis, myalgia, and leukopenia may be more common with influenza B than influenza A. And in 2010-2011, 38% of pediatric influenza deaths were caused by a B strain. So this does make a substantial contribution to burden of disease. As is true with influenza in general, the burden of influenza B disease varies from year to year. But if you look over a several year period, there is substantial contribution of B. So where are we, given that this is a problem and an issue, and we would be interested in having two B components in an influenza vaccine. Where are we in this? MedImmune has made a quadrivalent live attenuated vaccine called QLAIV. This vaccine was approved by the FDA on February 29th of this year and will be available for the 2013-2014 flu season. GSK has also made a quadrivalent flu vaccine and is expecting FDA approval in December of this year. There will be a limited supply of QIV available for the 2013-2014 flu season. Sanofi Pasteur is expecting approval in the middle of next year and will have a very limited supply of quadrivalent vaccine available for the 2013-2014 season. So plans for use of quadrivalent flu vaccines will likely evolve over the next several influenza seasons as more quadrivalent influenza vaccine becomes available. So one question that people might have is, will use of a quadrivalent flu vaccine compromise the influenza vaccine supply? And what I think is really true is our ability to have a quadrivalent flu vaccine is a real dividend of pandemic influenza vaccine preparedness. Over the last 10 years, our influenza vaccine manufacturing capacity has increased very substantially. And what you can see from this graph is what's shown in gold is the number of doses that were available of a trivalent vaccine. Then what's shown in blue is the number of doses that would have been available if a quadrivalent vaccine had to be made. And what's shown in the red line is the number of doses that were actually administered. And so what you can see is that although 5 or 6 years ago we didn't have the capacity, we didn't have the supply to be able to provide adequate amounts of quadrivalent vaccine, our manufacturing capacity is such that now we do have that capacity to provide quadrivalent vaccine. So in summary, influenza B infection is associated with a substantial burden of illness. Current inactivated and live attenuated flu vaccines contain only one influenza B strain, and prediction of strain circulation based on surveillance has been imperfect. Increase in influenza vaccine manufacturing capacity means that production of quadrivalent vaccine is unlikely to decrease availability, and quadrivalent influenza vaccines are expected to be available in limited quantities for the 2013-2014 influenza season, with more available in subsequent seasons. These are 3 individuals that I'd like to acknowledge for slides or for advice on this talk. Lisa Grosskopf and Jennifer Liang at the CDC, and Mark Sawyer at UCSD. And I'm happy to take your questions. Okay. There's a question here about that H1N1 influenza has a clear relationship with Staph aureus pneumonia. Does the H3N2 variant? We have not seen that yet, but bear in mind that we've only seen several hundred cases of the H3N2 variant virus. So not enough really, I think, to look at the association with invasive Staph aureus infection. But if these infections persist and spread, I think it's certainly something that we'll be able to look at. There's a question about when will the ACIP recommendations on quadrivalent influenza be published? What I would say is there are not recommendations yet because there is not vaccine available yet. It's likely that there will be some recommendations on use published before the coming influenza season, before the 2013-2014 season. I think, to be honest, I think the next couple of years are going to be a bit difficult and muddled because we're really going to have to tailor recommendations in part to vaccine supply. I think in 2 or 3 or 4 years things will be much clearer. We will have a much steadier and quadrivalent flu vaccine supply. But what I would say is stay tuned, because there will certainly be some recommendations coming up before the upcoming season. Will there be, there's another question, will there be a high-dose version of the quadrivalent vaccine targeted for over 65-year-old patients? That's a great question. That vaccine right now is made by Sanofi Pasteur, the current trivalent version. I think that they will have to see, I think it will depend in part on demand and in part on what they're able to manufacture. So I don't know the answer to that question just yet, but stay tuned. There's another question. Are there any changes in recommendations for flu vaccine greater than 6 months, for children greater than 6 months, 1 or 2 shots this year? So the answer is that the number of doses of vaccine will not, those recommendations will not change. So we will continue to recommend, as we have before, 2 doses for children under 7 years of age who have not previously been immunized, and 1 dose for those who have previously been immunized. But it's unlikely that those recommendations will change. There's a question, is H3N2 found only in swine? I think I understand that it's often very confusing because there is the H3N2 that has been circulating in swine for many years, and there is the human H3N2 that we're all very familiar with that's been circulating in humans for many years. Those viruses are really very antigenically distinct. The H3N2 exists in both humans and in swine. The swine virus is not one that we have protection against in our current vaccine, because our vaccines currently are manufactured to protect against human H3N2. Those viruses have been recovered and are available as seed viruses for swine H3N2 variant vaccine if the need arises. But at this point, that doesn't seem to be a priority because we've only seen a couple of 100 cases thus far. So at this point, I think we're going to finish up. I'd like to thank you all for your questions. I'm sorry I couldn't get to all of them. And I'd also like to thank you for participating in this presentation. I'd also like to thank Genentech and Cubist for their support of this important educational series. Please remember to complete the quiz at the end of the session to secure your CME credits. My name is Dr. Ruth Karen. Thank you for joining me.